Hello, everybody. Good afternoon, and thank you so much for joining us today. My name is Shannon. I am the U.S. Clinical Application Specialist for CereCare Medical, and I really appreciate you all logging in today. Just to let everybody know, your mics should all be muted, and they will stay muted for the duration of the webinar. We will have a live, well, we do have a live chat function that you can write in your questions throughout the entire duration of the webinar. At the end of the webinar, we will have a Q&A session where we will go over the questions, and Professor Østergaard will be able to answer them. And without further ado, it is my absolute pleasure to introduce one of the leading experts in brain perfusion imaging from Aarhus University, Professor Leif Østergaard.
Thank you so much, Shannon, and it's wonderful that so many of you could join. I'm going to talk about the technology behind perfusion maps. And for today's webinar, I'll have a special focus on acute stroke. So some of the things that we will cover. So what we'll cover is, first of all, what do we normally mean by perfusion imaging? And then I'll have a special focus today on perfusion imaging and what it says about oxygenation. And that's actually the reason why we choose acute stroke, because that's a condition, as you all know, where oxygenation is limited and tissue die as a result. And also how we think of perfusion in terms of how we manage patients. And then I'll introduce this new perfusion technology and tell you how that allows us to say something more precise about oxygenation. So first of all, as I just alluded to, perfusion imaging, we do that to address perfusion or tissue oxygenation. And what we do is that we, let a intravascular bolus passage of iodine, or in this case, MR contrast through the brain. And using that, we can calculate in every part of the brain the concentration of contrast agent, and the software, a perfusion imaging software, converts that into images of cerebral blood flow, as you see on the left. Notice how a CBF map has a lot of contrast between gray and white matter, and also between different areas of gray matter. So what you'll notice is quite difficult actually to see on CBF maps whether CBF is low or high, beyond what is the natural sort of tissue contrast. We also generate other maps. Cerebral blood volume, they look a lot like CBF images, but they show not the blood supply as cerebral blood flow does, but how much blood volume, so what is the density of blood vessels in a given part of the brain. And then finally, the mean transit time, the average time that the contrast spends in every voxel in our perfusion image. That's the ratio of the cerebral blood volume image to the cerebral blood flow image. And notice how that's pretty uniform, apart from these white areas where the ventricles are. And you'll see later how that is important, because it gives image contrast when perfusion is low. So this is what I'll call classical perfusion MRI. Classical means old. You can see how these algorithms I developed actually 30 years ago this year. So it's truly classic. So the reason why we're so interested in perfusion is, at least in neurology, is very much related to stroke. Because as you know, after a stroke, the patient gets symptoms. And what is very important is that initially, when the patient gets into the hospital, brain injury because of this tissue hypoxia that comes because of this ischemia may be limited, as you see in the top row. In this case, it's just sort of small areas in the perfusion territory that's affected. But as you can see in this diffusion weighted image, after 5 days, the tissue injury is enormous. And so, of course, there's a big interest in knowing, is this infarct when the patient comes in, is that the final infarct, or will it grow like it does here? Because then we really want to treat the patient. And this is where perfusion comes in. And I'll talk a little bit about stroke pathophysiology because it becomes important in what we're going to discuss later. So this is how we think of ischemic stroke today, namely that when blood flow all of a sudden drops because of a blood clot, then CBF drops immediately, and there's a specific threshold of cerebral blood flow at which there's no longer enough blood flow to sustain the normal neuronal firing of neurons. That means that the patient gets the acute symptoms that are characteristic of a stroke. But what is equally important is that tissue can actually sustain this, keep alive even though blood flow is low, at least for a while. We call that area the ischemic penumbra. And actually that penumbra is a term that is very central in stroke. It was developed by my PhD supervisor, Jens Astrup, 60 years ago this year, or rather last year. The reason why that is important means that this suggests that if we can restore CBF quickly, then we can normalize oxygenation and tissue can survive. I should see here, but if we cannot restore blood flow, tissue will die. This tissue injury will become irreversible and you'll have severe symptoms. So this is a very central concept in how we think of stroke. And because we think of stroke as a disease where tissue die as a result of low blood flow, and we take here blood flow to mean how much oxygen the cells have available to them, then of course the natural treatment is to restore blood flow by thrombolysis, dissolving the blood clot, or mechanically removing it. So for that, we talk of a treatment target. So what we can see on the image that tells us that here's a patient where we can salvage tissue. And this is where we have historically used the perfusion-diffusion mismatch, and some still use it. That is the difference between tissue that has died, as you can see on this DWI image already, and then the perfusion. Here you can see that there's low perfusion in an area here where tissue still hasn't died. So that's this mismatch. And this is what we then consider a treatment target. And you can see here how that died in this patient because blood flow couldn't be restored. So that's what we often use today, perhaps not NGT, but then Tmax that is provided by many softwares as a way to identify this treatment target. And I'll delve a little bit into this pathophysiology. Why is it that we're talking about low CBF, that is really the cause of what determines oxygenation? But then we look at these and maps instead, so the MCT or the Tmax map. Well, if we imagine what happens after a stroke, then what really happens is that the perfusion pressure gradually drops. It drops quickly, as a matter of fact. And actually, CBF doesn't drop immediately. You can see there's only after a while CBF starts to drop down to that minimum that you saw just before. And the explanation is that it's actually in the other map we report, namely the blood volume, because there's auto-regulation that, at least for some drops in perfusion pressure, can maintain a constant CBF. But at some point, that reserve capacity is exhausted, and then blood flow begins to go down. There's some area where there's still enough oxygen to drive neuronal firing. We call that benign oligemia. But then at some point, so roughly 1/3 of normal blood flow, symptoms develop. So this is where people get symptoms. And below that point, CBV starts to drop simply because there's not enough blood flow to keep blood vessels open. And as I told you before, the mean transit time is actually the ratio of these two maps, and that looks like this. So MTT simply goes up uniformly when this perfusion pressure goes down. So that's why MTT is such a good map to look at, also because the maps have not much contrast because of CVF differences between gray and white matter. So it's really easy to look at, as you see here. Okay, there's a problem. Even though we now have perfectly good treatments to restore blood flow, there are two problems. One is that, at least in my country, not all patients are eligible for acute stroke therapy. So only about 1/3 can actually, of the patients who come in and have a stroke, can actually don't have, for instance, contraindications against thrombolysis. And another, which is more severe, that even though we can restore blood flow successfully, half of our patients still don't get good outcomes. So that is, of course, led some to think, is there something wrong? Is blood flow and the penumbra, low blood flow and penumbra, not the whole answer to this clinical problem? And the one that I will explain to you today is that blood flow is not equal or equivalent to tissue oxygenation. That is the whole premise of why originally we've been using low blood flow as sort of a biomarker of poor oxygenation. And the reason for that lies in how capillaries function. So if you imagine capillaries, so the smallest blood vessels in the brain, blood flow comes in, runs through the tissue where cells extract the oxygen content, and then it leaves back and runs back through the venules to the heart again. So capillaries actually, well, they work fine, as you can see here, but if we increase blood flow through these capillaries, you can see what we call a transit time effect. Namely, that if we increase blood flow through these three capillaries, then the time available for tissue to extract its oxygen content actually becomes very short, and it becomes insufficient for tissue to actually extract blood's oxygen content. So this is a basic biophysical problem that has troubled people for many years. You can see how oxygen extraction from the color here is really poor down here, but very good at the top figure. So one of my countrymen, who was actually born quite close to where I sit in Denmark now, he came up with a solution for that that actually won him the Nobel Prize in 1920. He figured out, he was interested in this problem in muscles, but it's a problem in all organs, of course, that he imagined that capillaries open when blood flow increases. You can see how if you increase blood flow, then with more capillaries available, then transit time stay relatively long, so that oxygen extraction remains really good. But this also means that this assumption that oxygen availability is essentially the same as blood flow or proportional to is not true. It's determined by blood flow and capillary function. And I'll come back to the thing about stroke. What people have found out the past couple of decades is that capillaries, and especially small cells that sit around or surround capillaries, pericytes, they are contractile and they're quite vulnerable. So that means that during ischemia, capillaries start to close. So it means that we actually have what you could call what August Krogh would have called a de-recruitment, meaning that we go the opposite way. So rather from having many capillaries that are open to having quite few. So unfortunately, after August Krogh made this discovery, no one really bothered to look for what happens if capillaries, if recruitment fails, so if capillaries close, as we see here. So what is important here is that what people found out after Krogh's time was that they're never really in healthy tissue, they're never really any closed capillaries, but instead there's a continuous redistribution of blood flows, as you see in this figure. So the recruitment really means from going from very heterogeneous flows, as you can see in the bottom here, to very homogeneous flows. And you can see again here how the oxygen extraction fraction, so the oxygen that the cells can actually access, is quite good at the top, but poorer at the bottom. And now comes a parameter that we use when we talk about this. So one is the mean transit time that you met already, and you saw mean transit time maps. But as you can see here, we need one more parameter to talk about this phenomenon. And we call that CTH, or the capillary transit time heterogeneity. So that really tells us of, how disordered are capillary flows. And so it tells us something about how efficient oxygen extraction can be. And Kim Moritzen here, and I should say that the one you saw just before, Sune Jespersen, he developed a model so that based on mean transit time and transit time heterogeneity, we can predict oxygen extraction fraction. And Kim Moritzen then developed a technique so that we can measure this transit time and mean transit time, as you see over here. And this is in a patient with a internal carotid stenosis. You can see how transit time is prolonged, and so is transit time heterogeneity, and it normalizes after treatment. So we have the tools now we need to actually measure this capillary phenomenon and its impact on oxygenation. So the modern perfusion software provides the classical parameters that you saw in the beginning: cerebral blood flow, the blood volume, and the mean transit time, whereas the two new perfusion markers that Kim Moritzen figured out how to measure is capillary transit time heterogeneity, CTH, and then it also measures the relation between transit time heterogeneity and the mean transit time. We call that RTH, or coefficient of variation. The reason why that is important is that it turns out in our research that the ratio between those, so RTH, is remarkably constant in normal tissue. So it means it's this contrast-less image, like you saw mean transit time also is, and we'll return to how that is very important in stroke. And on top of that, using Sune's work, as you saw before, based on these, we can two parameters, we can calculate the oxygen extraction fraction. So essentially the oxygen extraction that tissue would be able to sustain with the microcirculation that it has. So it doesn't measure oxygen uptake directly, but it makes a biophysical estimate of how big OEF can be. And then it also calculates that OEF, the fraction of oxygen that's extracted, it multiplies that by CBF. And as you know, when you multiply that by the arterial concentration of oxygen, then you get a measurement of oxygen metabolism. So this is an estimate. Again, we don't measure oxygen directly, but with the microcirculation that we measure, this is the oxygen metabolism that this microcirculation can sustain with the CTH and MTT we have measured. So how does this look in stroke? So this is actually, I'll walk you through it. On the left, you see two patients, CBF measurements from two different patients. You can see that they have big middle artery occlusion just in opposite sides, one in left side and one in right side. But these CBF reductions are actually similar. So it means that they have, both a penumbra, according to the way we talked about hypoperfusion and stroke in the beginning. And these patients were not recanalized or could not be recanalized. That means that this was permanent ischemia, so they had this CBF, for days and weeks after their stroke. On the right, you see this parameter, the transit time heterogeneity, so RTH. And in the top patients, you can see how that is low. Here I'm an old-fashioned radiology person. I sort of like grayscales, but you can see how there's black below the top, the red arrow on the top leftmost panel, whereas there's sort of a pretty uniform RTH on the lower panel. And in the paper, as referred to here, you can see how we made some simulations. And what this low RTH seems to mean is that there are closed capillaries, meaning that that phenomenon that you saw in the beginning of how capillaries become closed during ischemia, that is probably what is happening in this in patient number 1. We then looked at these patients again later, and you can see how in the topmost patient, there's a huge infarction corresponding to the area of high or low RTH, whereas the other patient has hardly any, has no lesion at all. So you can see how this is a problem for the ischemic penumbra notion, that it's CBF alone that determines what happens here, whether tissue dies or not. What this suggests is that it's really whether capillaries can remain open or not. So it seems that in the topmost figure, this patient had capillaries that could not stay open. And that actually means, because you know that now, that if recruitment fails, there are fewer open capillaries, then the oxygenation decreases. So this concept we have that of the penumbra that is really sort of preserved low blood flow that maintains the same level until we reperfuse, that is true. But the same is probably not true of oxygenation, because if you have capillaries closing the whole time, then oxygenation will fall too. That means that the topmost patient may have had dwindling oxygenation in that penumbra, whereas the lower one has had a reduction in oxygenation and blood flow also constant, but because capillaries remained open, cells could sustain that level of reduced oxygen availability. So this is for patients who cannot be recanalized. And of course, this raises the question, what if we could preserve perfusion? What if we could give a pill in the ambulance that, would cause, capillaries to stay open? If we could somehow give patient 1 a pill so that brain looked like patient 2's brain in terms of RTH, could that tissue have survived? even without restoring blood flow. I know this is mind-boggling, but because capillary flows and CBF combined affect oxygenation, then you can actually do something with oxygenation by affecting capillary flows alone, even though you cannot restore CBF, at least theoretically. So hence the question mark. Let's look at the patients we can restore blood flow. And where we do restore blood flow, and I just sort of reiterate what you saw in the first slide in the top. The injury mechanism, as we think of it today, is that, there's low blood flow, there's ischemia, neurons are vulnerable to that, and they can only survive for a while. So therefore, over time, the core, the darkest red region, gradually increases, and without treatment, you would expect here then the whole penumbra will ultimately die. But the treatment is, of course, to restore blood flow, and we have thought that neuroprotection in terms of making neurons less susceptible or sensitive to low blood flow would help. But as you also know, that has worked very well in animals, but not so well in humans. And what we wonder is, of course, is that because it is really, the blood vessels that are the problem, or the capillaries that are the problem, that they are constantly closing. So we should be protecting those and accepting that neurons probably die when they sustain a certain level of hypoxia. And then we have that poorly understood phenomenon, the fact that even though we restore blood flow, we can't stop that, increase in or this demise of the core or the penumbra, as you see in the top. So imagine now, with what you've just learned, that what happens when we have a stroke is that not only does blood flow decrease, but we also see this phenomenon that you saw on the right, namely that capillaries become occluded too. So therefore, the fewer capillaries in the middle figure, simply because we imagine that some of those have been closed by the low perfusion pressure and by the low blood flow in general. When we then restore blood flow, you can imagine how two things can happen. One is that we mechanically, if let's say there are small clots in individual capillaries, or we can mechanically force the capillaries open, even pericytes are constricted, then we can restore capillary flow and come back to the normal situation. And of course, oxygenation is restored and you save the hypoperfused tissue. But you can also see that if we fail to reopen capillary, then we end in that situation with extreme shunting. And in fact, if you sort of make the calculations of what happens if some of your capillaries close, then you can work out that you actually don't improve oxygenation by restoring blood flow if your capillaries are still closed. So hence, it would be natural to assume that reperfusion would be futile if this is the case. So, of course, and there's a paper if you're interested in that calculation and an explanation of why is it that biophysically blood flow doesn't improve even though you restore blood flow. You can read this paper. But of course, it becomes really interesting. Is there medicine? We talked about it, if there's medicine we could give in the ambulance, we could stop this process, but it seems like it's equally important for in relation to us restoring blood flow, that we are able to see whether we have restored recruitment, if you will. And you can also see in that paper, which is written also by people who have studied these injury mechanisms. So what is it that makes parasites constrict? So there are some of the medicines that we use in medical work today that actually could potentially, sort of stop that constriction. It should be said, and wise people have reminded me of that. We should notice that even though we are, in the angio suite, we give some kind of medicine that may actually be more dangerous than we think, because that medicine may dilate, perfectly healthy capillaries and make this shunting even worse. So by essentially redirecting even more blood flow to healthy capillaries rather than entering this slightly, occluded capillary where the problem is. So this is something that people are starting now to look into in animal models now. So I just wanted to raise this, and I'm sure that the medical doctors here who do this, they are aware that this is probably not something with a quick fix. In terms of, how can we do this while we still have the opportunity to treat, let's say, with additional thrombolytics, if it's little thrombi that keeps the capillaries open, or simply mechanically with saline injections, then there is actually software on the way that of this modern perfusion imaging, where you can generate maps of CTH as well, so that potentially you could make the images you saw before that were made by MRI, that in the future, we hope that you'll be able to, or people who do neurointervention will be able to have those maps available also in the angio room to sort of tell where the capillaries have opened after they have restored blood flow. Then a small sort of, practical, and we're so blessed that people are now starting to do these, to conduct this kind of perfusion imaging in acute stroke studies. And here on the right, I show one of these examples where people have looked at acute stroke patients, and then they have used these perfusion MRI images to calculate OEF, as you saw we can do with Sune Jespersen's software. And what is really, really exciting here is that you may notice that I presented as kind of as a truth in the beginning, that if you have, a DWI lesion, then tissue is dead, like irreversibly dead. But what they were able to show is that, and you can see in the top image, that even though there was a huge DWI lesion, if there was high OEF, then actually after successful thrombectomy, that lesion went away and tissue looked normal. Whereas if, as you see in the bottom, that if OEF was low, then that lesion persisted. And I want to tell something, that you should be aware of here, is that we do measure what OEF could be if cells were using oxygen at the rate that it's provided to them by the microcirculation. So this could well be the actual OEF you see, you would measure if you had a PET scanner in the top, and the same for the bottom when you're just lacking capillaries, and so OEF is not very high. But really, it is that biophysical. What you do measure is whether capillaries are still open and permit the oxygen extraction that cells really need. But just sort of to make that clear. But just to sort of summarize, if you that tissue oxygen access is not determined by CBF alone. It determines the supply of oxygen, but CTH and whether capillaries are open affect whether oxygen can be extracted. And tissue hypoxia and tissue injury, ischemia means, it's Greek, means low blood flow. But if we have poorly functioning capillaries, then oxygen can be low irrespective of what CBF is, or it can be high, as you also saw in one of the cases. So it's important that we are getting more of the full picture as the one you see on the right, where we began with thinking of the hemodynamics, the blood flow in stroke, to now also look at what is oxygen extraction and what is the CMR2 that cells essentially can produce or have in the tissue given the high hemodynamics we see. So this is why we think that this is going to tell us a lot of new things about stroke. And just to put out a little advert from some of the later seminars is that there we're going to be discussing, what this microcirculation and its impact on oxygenation, what that means in other diseases. But in this case, we focused on the microcirculation in stroke. So with that, I want to stop my lecture. Thank you for your attention, and then we'll go to questions.
But I'll ask you, Professor Østergaard. So these are a lot of new biomarkers, right? CTH, OES, yeah. CMR02. And for a lot of radiologists, neuroradiologists, they're not used to seeing advanced biomarkers like this. A lot of them maybe aren't even used to seeing perfusion maps, right? Perfusion is not widely used. What advice would you maybe give when they're just starting to learn how to interpret these maps and maybe even trusting what they're seeing in like OEF and CTH, for example?
Right. So my advice would, and that's why I started with showing the main transit time maps, because those are maps that sort of began to emerge in the late 90s, so probably before some of the people who are listening in were even born, I would imagine. But what is so nice about them is that it's easy to convince oneself that if you have a bright area on the perfusion, the MCT maps or the Tmax maps, as many also are used to look at, that means hypoperfusion. That means something is wrong, that oxygenation is threatened in terms of the blood flow to a certain region. And the CTH maps in themselves are, in my experience, they are actually difficult to look at because they look a lot like the MCT maps. So all of the lectures I'm going to be giving and what I've showed you today, where I used direct perfusion maps, if you will, I showed the RTH maps, so the transit time heterogeneity divided by its mean. So you should think of that as everything in nature that we can measure, the standard deviation of something and the mean, they all always follow each other. And we've measured this in a lot of diseases. So when that ratio between transit time heterogeneity and mean transit time is disturbed, then something is wrong. And it's always wrong, it seems, in a bad way, that oxygenation is impaired. So think of abnormal transit time heterogeneity as a condition where, so here blood flow is actually affected, but what you'll see in some of the following lectures is that there are even diseases where blood flow is normal, but oxygenation is really poor. And we can only see that looking at the transit time heterogeneity maps. So if I was to give a recommendation to people, I would look at the OEF maps. So maybe I should try to see. I wasn't very good at sharing my screen before, but these maps, the OEF maps, they summarize in a very nice way how the blood flow and the transit time heterogeneity, how they combined affect oxygenation. So this high OEF is clearly, is very visible compared to the other side. And of course you could say, oh, but it looks normal down here. And there's a little bit of context that people should be into, namely that in ischemia, so whether it's stroke or whether it's carotid stenosis, the diagnostics people are used to look at to see whether carotid stenosis is severe or not. And also in stroke, it's very difficult to measure there, but a high oxygen extraction is a very bad sign because it means that there's simply not enough blood flow coming in for, to support the needs of the tissue, meaning that it's extracting more than normal. So actually people diagnostically will often, send people to nuclear medicine department to have a PET scan to measure OEF instead, but that's a very expensive, very, if you have access to these kinds of measurements, and it's impossible to do in stroke because it takes an hour or 1.5 to do with a PET camera. But what this means is that you can actually do that you get an estimate of what the oxygen extraction is like by simply looking here. And a low oxygen extraction when you have a condition with ischemia is very bad because there's low blood flow but not a lot of oxygen is being extracted. That means that tissue, if it was PET, that tissue had died, but it also means that you not be able to, even though you restore blood flow, you'd not be able to extract oxygen. But other than that, that would be my recommendation. Start looking at the OEF maps because they're very crisp, or the dull RTH maps that I showed you in the beginning, where it becomes all black, where the problem is in stroke.
Wonderful. That's excellent. Thank you. We do have some questions also for you. I have Chris.
Perfect. I was trying to just keeping, the dance going until people felt comfortable. Wonderful.
Yeah. So Chris, first of all, thank you for the nice presentation. It was truly a pleasure to see regarding the parameters that are being estimated. A lot are based on CBF. However, quantitative CBF depends on the accuracy of AIF determination, which suffers from various effects, including signal saturation, partial volume effects, vessel selection, etc. If quantitative CBF is suffering from that many biases, how does this relate to CTH, OEF, and CMRO2, as these are based on CBF? That is a very good question, Chris.
That is an excellent question. Thank you for that. So, it's true that CBF measurements, they are not absolute in the sense that, so actually there are ways to calibrate and make them quantitative, but it's not like PET, for instance, or like ASL for that matter. So the question is how do we know, for instance, that what really matters is in ischemia is whether CBF is lower than 20 milliliters of blood per 100 grams per minute. And the way I look at, if I were to look at maps and say, is there ischemia here? I would simply compare CBF with the image intensity I see in white matter, because white matter has a absolute blood flow of 20 mLs per 100 grams per minute. So that's a way I get around the fact that CBF measurements are not quantitative. Then to the other essential, so is a completely true and really good remark. How can we then say something about OEF? So the thing here is that mean transit times, they are the ratio between two parameters that both have, this uncertain proportionality constant in front of them. So that essentially means that the mean transit time and also the mean transit time heterogeneity parameters we get, they are absolute. So they're in seconds. And so is the, that is the OEF that we can derive from that. That's also a parameter that, you can essentially trust in a way. But then when we calculate it by CBF, we run into that same problem as before. And here again, when I look at images and then I compare it, for instance, if it's a focal lesion, then I compare it to cortex in the contralateral side, for instance, to see whether the is accurate. I should also say that we have published, so what I just said before, that if we take those proportionality constants into account and essentially make absolute maps and compare them to gold standard CBF maps. There's a publication out from my group where we compare that to absolute CMR2 and absolute OEF maps in normal humans, where we can actually sort of, there's a fairly good, relatively good agreement between the two. And I know that this is being looked at in animal models of stroke as well. So there will be more out about how reliable are these biophysical estimates that are shown.
Great. We have another question, George. Are surgical interventions guided from these maps? If so, do you envision any real-time imaging modalities for perfusion that could assist the surgeon?
Sorry, could I have the first part of the question again?
Are surgical interventions guided from these maps? And if so, do you envision any real-time imaging modalities for perfusion that could assist the surgeons?
So I think what you're alluding to would be, so what I showed just before, that would mean that during neurointerventions, for instance, thrombectomies, you be able to monitor it, before and after your treatment, what has happened. If it's, for instance, in relation to revascularization, so for instance, stenting or something, there are already some studies out where people ask that question. When we have restored blood flow by inserting our stents, then we know that the underlying disease, so the atherosclerosis, I mean, you've fixed the large vessel problem. Is there also small vessel disease in the microcirculation? You sort of distal to that, and so the publication that I showed there, this seems that there may be some residual, capillary dysfunction even when you restore blood flow. So to your question, the medical treatment that comes after or that you maintain after your vascular surgery that might be a very interesting question to address, whether there's, you should really maintain sort of aggressive treatment for whatever microcirculation problem that has, been during the stenosis.
Thank you. Leon, is there a publication you can recommend to read up on the physiologic background of advanced perfusion imaging?
That is a very good question. So I wrote a review back in 2020 about why this recruitment or why capillary blood flow is important. And in that, I try to explain sort of some of these parameters and also what they look like, images look like. There's also one from 2015 called Capillary Dysfunction, Why is it important and how do we measure it? And there's some example actually from both carotid stenosis and from dementia that one can look at to sort of get a feel for why are these extra parameters important. But I think it was made, I don't know whether that would, but I also hear that maybe we should get, an easy to understand review or something out there to explain that. That it won't be out in a week or so, but I'll take that to heart with some of colleagues to maybe, work on that.
In the other chat, we did have a question. In the slide showing the OEF of reversible versus non-reversible DWI lesion, where the lesion and flare demarcated in the initial stroke. Oh, were those lesions flare demarcated in the initial stroke imaging? Can we expect a flare mismatch, or rather, in which cases should we expect the OEF flare mismatch in the initial stroke imaging?
That is a brilliant question. And in this case, I say that because, and you can probably see that already, that I don't have a good answer for that. So I would actually, the reader should really shoot a question to Alex Bannisato from Lyon, who may publish this excellent study. It's an excellent question, and I simply don't remember right now.
Okay, and we can connect
it's
you.
It's a very
Dr.
bright
Zan.
and observant bunch of listeners we have. Thank you for that.
Yeah, yeah, and we can connect you, Dr. Zanan, with Dr. Bannisato if you'd like to ask that question. And then also, okay, oh, Jaren, hi. Thank you, Professor Østergaard. It was a very informative talk. I was wondering which advanced parameters you would suggest best reflect tissue viability, CTH, CMRO2, or OEF. And it's the same person. Is DSC MRI perfusion preferable to CT perfusion for generating those advanced parameters, and why so?
So I think to the first, I would actually say what we touched on in the first question, that I think OEF maps, or alternatively the RTH maps, would be preferable because they're simply the easiest to look at. So OEF or RTH. And I really love the OEF maps because they have color. It's easy to see, whereas the ones I showed, the problem area becomes dark, and that's kind of, counterintuitive. I think MRI and CT perfusion are equally well suited to do this. I think, the perfusion maps of OEF and CTH, MGT, CTH, and so forth, they look brilliant on both CT with CT perfusion and DSC. So,
And that is all I have for you, unless anybody else has any other questions.
I am so grateful for so many people attending and for the great question. I hope that, on my screen, you're all, wonderful douche sort of, colors, and that maybe we'll see each other in real life one day. And yeah, but thank you for your questions and also for the hard ones that I couldn't answer. And Alex is a great guy, and he'll love to discuss more how they're the place in the world that are the most advanced, together with the group in Italy on these maps now, and also a group in San Francisco to do fantastic work on this, and I should look that up.
Thank you very much, everybody, for joining. It was fantastic to have you. We very much appreciate you. We will have Professor Østergaard again on Thursday, June 11th, same time, same place. We will send the link out again. We look forward to having you. The next webinar will be called The Future of Perfusion Imaging, New Biomarkers and AI in Brain Imaging. We hope that you will join us for that as well. And hope everybody has a fantastic rest of their day. Thank you very much for joining us today.
See you.
Bye-bye.
Bye.